Good afternoon, everyone. It gives me an immense pleasure in welcoming you all for the topic imaging in fungal sinusitis. I welcome the chairman, the respected team, medical superintendent, the deputy medical superintendent, the vice principal, controller of examinations, and our speaker, Dr. Ramachandran, and all the department HODs, professors, associate and assistant professor, SR, JR, CRL, and students. And also, my good Dr. General Nadan, HOD, for addressing the speaker and regarding the topic.
Thanks for joining us. Before starting the webinar and introducing the speaker, I'd like to ask our dean to say a few words.
Good morning to one and all. Respected our beloved chairman is birthday today, so for that only I went and come back. I wish him and come back. Respected chairman and his family for giving an opportunity for this arranging webinars, and our medical superintendent, our vice principal, and Professor Dr. Cellulitis, Department of Radiodiagnosis, Dr. Deepak, and Dr. Divya. So all the faculties of the Annapurna Medical College Radiodiagnosis. The guest speaker of today, Dr. Ramachandran, I welcome you, sir, on behalf of the management and the administration for this wonderful topic, imaging and fungal sinusitis. It is a hot topic today. So we like to know a lot of imaging techniques and what you do and how to diagnose and everything. Because of the corona, the radiodiagnosis will take a major role. So like that, now it's a fungal infection also is coming into the surface. That also we like to know. I think it will, most of the delegates who registered in our college are from outside. In other side also, we benefit out of this your lecture. Both we throw some light upon the how to diagnose, pick up early, diagnose all these things we cover up. Congratulate the Department of Radiodiagnosis for arranging this webinar on imaging fungal sinusitis. I thank the Dr. Ramachandran for accepting our invitation and coming in and speaking on this webinar. So I wish you all the best as the Department of Radiodiagnosis. Thank you very much for giving an opportunity.
Thank you, sir.
Thank you very much for your kind words and encouragement and support. At this outset, I would like to extend our wishes to our beloved chairman from the Department of Radiology, and we wish him a very long life and his continuous support for the Department of Radiology. So, I know Dr. Ramachandran since 1 year, and he has done his MBBS in Madras Medical College and completed his MD in Radiodiagnosis at Quantum Medical College. And he has experience of working in Royal Care Coimbatore. Since 1 year, he has been working as an assistant professor at Government Mohan Kumar Medical College. He also is a consultant at Neuro Foundation, Salem. We do have an array of cases from early cases to the complicated cases. I think it will benefit everyone who is attending this seminar in identifying fungal lesions and managing the fungal lesions. I think it will be very useful for the clinicians as well. So, with this few words, I'd like to invite Dr. Ramachandran to go ahead with this webinar. Thank you.
Thank you, sir. Sir, can I share screen, sir?
Yes, sir.
Good afternoon, everyone. Before I'm going to start this presentation, I want to thank Chairman and Dean Sir of Annapurna Medical College and Hospital and Dr. Senthilnathan Sir for giving me this opportunity to speak in front of all of you. Today, I'm going to talk about imaging in fungal sinusitis. And before that, a brief introduction about COVID-19 pneumonia. COVID-19 pneumonia originated from Wuhan, China in December 2019. And as we speak now, there are about 19 crore cases worldwide, along with 41 lakh deaths. Prevention in the form of vaccination and social distancing and early management are key factors in combating this deadly disease. Second wave is proving to be more deadly than the first wave, probably due to mutant strain and associated secondary infections, etc. And one of the deadliest secondary infection is what we are going to speak about today, which is mucormycosis. Mucormycosis is a fulminant form of zygar mycosis.
Doctor, 1 minute. We are not able to see your screen.
Back. Slides.
Slides you are not.
Share your slides, sir.
Sir, 1 minute, sir. 1 minute, sir. Can you see this?
No,
Yes, sir.
open up,
You have
sir.
to open it.
Open it.
Can you see now, sir?
No, not that. You have to.
We can see your screen, sir, but you have to open the PowerPoint and go for slide share. Now we can see, sir.
Okay.
Yes, sir. Yes, sir. Thank you, sir. Okay, a brief introduction.
You have to show a slideshow.
Slideshow.
Click the slideshow.
Yes, sir. Now, sir.
Okay.
Yes, sir. Okay, a brief introduction about the illness. COVID-19 pneumonia originated from Wuhan, China in December 2019. And as we speak now, there are about 19 crore cases worldwide and about 41 lakh deaths. Prevention in the form of vaccination and social distancing, early management are key factors in combating this deadly illness. And second wave is more deadly than the first wave due to mutant strain and secondary infections. And one of the deadliest infection is what we are going to talk about today, which is mucormycosis. This is a fulminant form of zygar mycosis caused by Mucorales family. Though the global incidence is very low, ranging from 0.005 to 1.7 per million, in India it is about 80 times higher than the global incidence, which is 0.14 per million. And it has a fatality rate ranging from 50 to 80%, and the prognosis is very poor. So etiology, mucormycosis caused by Mucorales family, which includes Mucor, Rhizopus, and Abscess. All are branched aseptate hyphae. They are saprophytic fungus and they are ubiquitous. They are present everywhere in the environment, ranging from soils, air, body orifices, manure, dust and napkins, etc. There are various forms of mucormycosis, which include rhino-oculocerebral form, pulmonary form, cutaneous form, and GAT form, among which we are going to talk about rhino-oculocerebral form of fungal mucormycosis today. So pathology, after inoculation occurs via inhalation of the spores into the nasal cavity and nasopharynx. From the nasal cavity, it can enter into the paranasal sinuses. And once it enters the paranasal sinuses, it can extend anywhere into orbit, masticator space, pterygoid space, infratemporal fossa, or intracranial extension can also occur. So it has a propensity to spread through the perivascular channels. So bone destruction is not necessarily needed for the fungal to invade the extra sinus. And it can cross the bony sinus walls through penetrating vessels and can reach the periantral soft tissue of the maxillofacial region, orbit, and cranial cavity. So why sudden increase in post-COVID patients? Why all of a sudden mucor is seen in post-COVID patients? There are various hypotheses postulated for this. Among them, some are depleted adaptive immune response in post-COVID patients and improper use of humidifiers, use of industrial oxygen instead of medical oxygen, increased zinc usage leading to growth of the fungus. Metal ions are needed for fungal growth. So increased zinc usage as a prophylaxis can also lead to growth of the fungus, thereby increased incidence of post-COVID mucormycosis. Use of the same wet cotton cloth mask for prolonged duration can also increase the incidence. Excessive use of steam inhalation, which may alter the nasal sinus mucosal flora, and voriconazole prophylaxis. So post-COVID mucormycosis is pathology is interleukin-6 driven high ferritin synthesis. As I said before, metal ions facilitate the fungal growth. So high ferritin level will facilitate the fungal entry and growth, and the fungus gains entry into the blood vessel through endothelial damage, which might have happened in COVID patients. And once angioinvasion occurs, fungus adheres to the vessel wall. There it initiates vessel thrombosis. And once the vessel is thrombosed, tissue necrosis occurs and a black estuary formation will result in. So angioinvasion will result in vessel thrombosis, which is followed by tissue necrosis. So what are the common risk factors for mucormycosis? Uncontrolled diabetes, post-organ transplant patients, patients in prolonged steroid therapy, hematological malignancies, renal failure, patients on immunotherapy, and post-COVID with or without any of these risk factors. Post-COVID is itself a risk factor for mucormycosis. So what are the common symptoms? Patient develops severe headache, which is the commonest presenting symptom. Eye or facial swelling can be present, nasal block, facial pain, toothache, and bloody nasal discharge. Clinical signs include facial and orbital swelling along with discharge, loosening of teeth, blackish discoloration of mucosa, proptosis, vision loss, eye movement restriction, and multiple cranial nerve palsies. So this is the black estuary, which is due to dead tissue in the nasal cavity. So clinical diagnosis is through nasal endoscopy, where they can visualize the black estuary, and nasal swab can be taken for microscopy and fungal culture, and sinus biopsy is done if it is clinically indicated. So this is the nasal endoscopic image of whitish appearance of the mucor. Here we can see the devitalized part appearing white compared to the vitalized reddish appearing normal sinus mucosa. So what is the role of imaging in fungal mucormycosis? We have pointed some of the important roles. One is early diagnosis. This is extremely important. Since the disease is rapidly progressive, once we pick up initial findings, we need to communicate immediately to the clinician, which will be helpful in managing the patient early. So early diagnosis results in early management, which will result in early recovery. Once we do not allow that, once we allow the disease to flourish, late diagnosis will result in extra sinus spread, which will result in debilitating effects for the patient, disfiguring surgery, or even deaths. Assessment of disease extent. This is important because management differs depending upon the extent of the disease. When the disease is confined to sinus cavity, management is different. It needs only endoscopic sinus surgery and antifungal administration. When it spreads to orbit or masticator space, infratemporal fossa, or intracranial extension, management differs entirely, and it needs multimodality approach for treating this patient, which might be gruesome for them. Planning the surgery. Discussion with surgeon is important to understand the clinical and nasal endoscopy findings, thereby helping him in additional imaging findings, which might be helpful for the patient. Follow-up evaluation. Comparison with the prior imaging is essential. So pre and post-operative images can be compared, which might be useful in follow-up. So how to classify fungal sinusitis? We have broadly classified this into non-invasive and invasive. Non-invasive when it is present within the sinus cavity, which includes allergic fungal sinusitis and fungal mycetoma. Invasive when it is present outside the sinus, which includes acute invasive fungal sinusitis, chronic invasive fungal sinusitis, and granulomatous invasive fungal sinusitis, among which we are going to see about acute invasive fungal sinusitis today. So what are the imaging modalities we have? MRI with the contrast is the imaging modality of choice. This is because of its superior soft tissue resolution. And also we can assess the intracranial, neural, and vascular extension via MRI. So MRI, PNS, and orbit along with MRI, along with brain with the contrast needs to be done. CT, PNS, they are available everywhere. It is quick and cost effective. They can be used for, CT can be used for initial diagnosis when there is high index of suspicion in the patients, or only when there is extra sinus spread, we can assess using CT. So first we will see about MRI imaging of fungal mucormycosis. So how to plan the patient for MRI? MRI brain with the PNS and orbit needs to be done in supine position with dedicated head coils. A initial scout T1 weighted sagittal image is taken, which acts as the localizer from which T1, T2, and flare sequences are taken. And brain sequences include T1, T2, flare, diffusion weighted images, and post-contrast T1 fat set in 3 planes, axial, coronal, and sagittal. And thinner sections are taken at skull base level for assessing the orbital apex, cavernous sinus, cranial nerves, and vascular assessment. And MR angiography to be done to assess the intracranial internal carotid artery and its branches. To predict angioinvasion, we need to do MR angiography. Also, we can do 3D cyst sequence for identifying perineural spread and cranial nerve infiltration. So for imaging wise, we can classify the disease into 3 stages: when it is confined to sinonasal cavity, when there is orbital extension, or when there is intracranial extension. But this doesn't indicate progression of the disease from one part to another part, because intracranial extension can occur without orbital extension also. When it is present close to ethmoid sinus through cribriform plate, it can enter into the brain. So it doesn't follow the progression, but for imaging wise, we are classifying it into 3 stages: sinonasal cavity invasion, orbital extension, and intracranial extension. So what is the earliest finding when it is present within the nasal cavity and sinuses? It shows hypo to iso-intense inflammatory mucosal thickening at nasal cavity and sinuses. Hypo to iso-intense inflammatory mucosal thickening, as we see here in maxillary sinuses, bilateral maxillary sinus show hypo to iso-intense signals within the maxillary sinus, which is covered or which has a peripheral rim of hyperintense mucosal thickening. So these hypo to iso-intense signals indicate fungal elements which alter the signal intensity. So this is the earliest sign which we see in sinonasal cavity involvement. Also, we can see ulcerated nasal septum and mucosa, which will show black turbinate sign. And next is soft tissue infiltration of the periantral fat planes. So anterior and posterior periantral fat planes will show soft tissue infiltration in the form of intermediate to hypo-intensity on T2 weighted images and flare images. Next is lack of contrast enhancement. This is highly suggestive of tissue necrosis. This is a sign of angioinvasive fungal sinusitis, which we commonly say as black turbinate sign. So this is the black turbinate sign, which we can see now. Here we can see in the right side, we can see the normal enhancing superior and middle turbinates along with ethmoid sinus cavity. Compare this to left side, where we see total lack of enhancement of the left superior and middle turbinates along with ethmoid sinus cavity. Also, we are seeing lack of contrast enhancement within the maxillary sinuses also. So this is the black turbinate sign. This is highly suggestive of angioinvasive fungal sinusitis. Also we are seeing some form of orbital extension also in the form of non-enhancing soft tissue within the medial compartment of the left orbit, which indicates left orbital cellulitis also. So this is another case which shows black turbinate sign. Here we can see nasal septum, which is non-enhancing. So as I said before, nasal septum and middle turbinates are the most common sites of early infection. So non-enhancing nasal septum along with non-enhancing right superior and middle turbinates. Compare this to left side, where we see normally enhancing superior and middle turbinates. So this is the earliest finding, which when we pick this before entering into orbit or intracranial extension, mere doing of endoscopic sinus debridement followed by antifungal administration will cure the patient rapidly. So this is another case which shows non-enhancing nasal septum along with devitalized mucosa. Here the patient, here it doesn't spread to either sphenoid sinus or into the both orbits or intracranial extension. So these are very early findings. Next is orbital extension. So earliest sign of orbital extension is preseptal and eyelid thickening. They will appear as high signals on T2 fat set and stir sequences. Next is edema and thickening of extraocular muscles. So involvement of conal compartment will result in thickening of the extraocular muscles, commonly medial and inferior rectus, because of its adjacent propensity to sinus cavity. They are commonly involved compared to superior rectus or lateral rectus muscle. They will appear as hyperintense on T2 and flare images and will show enhancement on post-contrast studies also. Next is stranding of extraconal and intraconal orbital fat. So orbital fat stranding is indicative of orbital cellulitis, which indicates orbital involvement in invasive fungal sinusitis. Later on, optic nerve involvement can occur. Optic nerve involvement can manifest as diffusion restriction, and it will show enhancement on post-contrast gadolinium images. Later on, orbital apex involvement can occur, and through the orbital apex, it can enter into cavernous sinus and it will have intracranial extension also. So all this later on, that there is thickening of the extraocular muscles, fat infiltration and edema, all can raise the intraorbital pressure, which will result in compression and distortion of the globe, resulting in guitar pick sign. So guitar pick sign is another classical sign of fungal mycosis like black turbinate sign. This occurs in later stages of orbital extension when there is raised intraorbital pressure because of the extensive edema and fat stranding, which will cause the compression and distortion of the globe, resulting in the shape of guitar pick, which is called as guitar pick sign. So here we can see left medial rectus is bulky and edematous compared to right side. And it is also appearing hyperintense compared to its normal opposite counterpart. So in fungal sinusitis, we need to always compare with the opposite side before going with diagnosis. Also, we can see minimal hyperintense soft tissue here in preseptal space and also in the periantral fat planes. Plus orbital fat stranding is seen visualized within the extraconal and conal compartments of the left orbit, along with inflammatory mucosal thickening within the ethmoid sinuses. So this is a case of acute invasive fungal sinusitis with left orbital cellulitis. So this is a guitar pick sign, which I have told you before. Here, because of the raised intraorbital pressure, we are seeing distortion of the globe, assuming the shape of the guitar pick, so resulting in guitar pick sign. So this sign is considered as a bad prognostic indicator. Once we see this sign, we can manage the patient only via orbital exentration or orbital decompression. This needs to be done for saving the life of the patient. So this is a bad prognostic indicator as in terms of fungal mucormycosis. Next is intracranial extension. As I told you before, sinonasal disease will manifest with ulcerated nasal septum and mucosa, hypointense soft tissue signals, along with periantral fat stranding and black turbinate sign. Orbital extension will present with eyelid and preseptal thickening, thickening of extraocular muscles, optic nerve involvement, orbital apex involvement, and later on guitar pick sign can result. When there is intracranial extension, what we see is cavernous sinus thrombosis. Cavernous sinus thrombosis is diagnosed by poor enhancement of the cavernous sinus along with bulging or enlargement on post-contrast gadolinium images. So whenever we see poor enhancement of cavernous sinus along with adjacent sinomucosal thickening, we need to think about cavernous sinus involvement in the form of thrombosis. Also, internal carotid artery involvement can also occur. Here, look out for stenosis. Stenosis is always compared with the opposite side. Look for the asymmetry, compare it with the normal side, and also see for the adjacent mucosal thickening. So stenosis can occur, thrombosis can result, dissection can occur, or pseudoaneurysm formation. All can happen when there is internal carotid artery involvement. So look for stenosis, thrombosis, dissection, and pseudoaneurysm formation. All this can lead to acute infarcts, which will appear as diffusion restriction. Mycotic aneurysms can also lead to subarachnoid hemorrhage, which will appear as flare hyperintensity in sulcal spaces and cystins. Lobectomeningeal enhancement can also be seen, which will be hypointense in pre-contrast images and will show enhancement in post-contrast images. Fungal early cerebritis can occur. This will appear as high signal on flare images and enhancement on post-contrast images, which we'll see later. Intracerebral fungal granulomas can result, which will be hypointense on both the T1 and T2 weighted images with the minimal contrast enhancement. Also, white matter edema can be present, which will be hyperintense on both T2 and flare images. Fungal abscess formation can occur, which will show rim enhancement on contrast image with the central non-enhancing necrotic areas and diffusion restriction. Later on, perineural spread and cranial nerve infiltration can also occur, which needs to be evaluated, as I said before, by a 3D sequence and all. Trigeminal nerve is the most commonly affected nerve because of its proximity to skull base. Here, look for the thickening of the nerve and nerve enhancement along the entire course up to brainstem. Commonly, look at the Meckel's curve for any T2 fluid signal loss along with enhancement on post-contrast images. So intracranial extension can either manifest as cavernous sinus thrombosis, internal carotid artery involvement, mycotic aneurysms, leptomeningeal enhancement, early cerebritis, intracerebral fungal granulomas, white matter edema, abscess formation, and perineural spread. So this is the diffusion restriction. Here we can see both maxillary sinuses occupied with hypointense signals, which show diffusion restriction, which is indicative of fungal infection. So next is CT. So next imaging modality is CT. How to plan the patient for CT? We need to do contrast enhanced CT of PNS and nasal cavity along with brain, which needs to be performed after IV bolus injection of non-ionic iodinated contrast. The dose is 1 to 1.25 ml per kilogram body weight. So thin axial sections of 1 to 2 mm sections needs to be taken in both soft tissue and bone window for evaluating the disease, and multiplanar images to be reconstructed along coronal and sagittal planes from the axial set of images. Once the axial set of images are taken, we need to reconstruct it and view it in coronal and sagittal planes for better identification of the illness. So what are the common CT findings in acute invasive fungal sinusitis? Appearance of mucosa is isodense to hypodense. We all know allergic fungal sinusitis will appear hyperdense in imaging. Compare this to isodense to hypodensity in acute invasive fungal sinusitis. This is because of the presence of fungal elements which alter the density and intensity in MRI also. Also, opaque sinus cavity, bone destruction can occur later on, nasal septum ulceration, and fat standing outside the sinus. Now we will classify the CT findings into 3 stages also, like in MRI. So when it is present within the sinus cavity, the most common sites are middle turbinate. They have a unilateral predilection. Middle turbinate and nasal septum are the most common sites of infection, and along with maxillary, ethmoid, and sphenoid sinuses. The early findings are ulcerated nasal septum along with the emphysematous mucosa and turbinates with inflammatory mucosal thickening appearing hypodense to isodense at nasal cavity and sinuses with or without fluid levels. And the disease can extend through the perivascular channels and hence can be seen outside the sinuses without intervening bone destruction. So to classify it as acute invasive fungal sinusitis, we do not necessarily need bone destruction to be tagged it as acute invasive fungal sinusitis. Always look for the additional findings, look for fat standing, look for soft tissue edema and thickening, look for thickening of extraocular muscles, look for optic nerve involvement, look for orbital apex disease. So bone destruction is not necessarily present in acute invasive fungal sinusitis. So also look for soft tissue infiltration of periantral fat planes. Anterior and posterior periantral fat planes along with pterygomaxillary fissure and needs to be evaluated for soft tissue infiltration, and look for erosion or infiltration around the nasolacrimal duct and sac. Orbital extension in fungal mucor mycosis, they occur through 2 routes. One is through orbital floor and medial orbital wall. Since the medial orbital wall is thin because of the very thin lamina pauperia present there, any small defects or any through the penetrating vessels, it can enter into the orbit. The next route is extension along the nasolacrimal ducts. So any form of soft tissue thickening or erosion around the nasolacrimal duct is considered to be early finding in case of orbital extension, and this needs to be carefully looked at when we are viewing the images. Next is fat standing and soft tissue in the pterygomaxillary fissure extending into the infratemporal fat. This is for finding the extension into infratemporal fossa. We need to look for fat standing or any soft tissue present there. Finally, bone erosions. Though bone erosions are not necessarily needed for tagging it as acute invasive fungal sinusitis, it may show bone erosions also in the form of nasal septum destruction, turbinate erosions, erosion of the floor of maxillary sinus, and reduced density of the maxillary alveolar bone around the tooth sockets, and hot palate infiltration. So bone erosions can be present in early or later stages of the disease. So orbital extension, CT findings in orbital extension include, as in MRI, preseptal and eyelid thickening. So any soft tissue density or thickening in the preseptal space and eyelid thickening is considered as early sign of orbital extension among the patients. Edema and thickening of the extraocular muscles, fat stranding, orbital fat stranding with or without extension or without enhancement, which indicates orbital cellulitis, phlegmon or inflammatory mass with or without abscess formation, optic nerve involvement, and orbital apex disease. Intracranial extension, as seen MRI, cavernous sinus thrombosis and carotid artery involvement can result, which will result in narrowing of the arteries, thrombosis, dissection, and pseudoaneurysm. For this only, we are doing contrast enhanced CECT of PNS and orbit along with brain. Arterial involvement can result in mycotic aneurysm, which can result in SAH and occlusion, leading to acute infarcts. Leptomeningeal enhancement can be seen, and other manifestations are fungal granulomas and abscess formation. So these images show extra sinus invasion in the patient. In the first set of image, we can see soft tissue density in the anterior periantral fat plane and also in the posterior periantral fat plane. Always compare with the opposite side. Here we are seeing a thickening and edematous anterior fat plane. Here we are seeing in the left side, we are seeing normal fat density in the anterior periantral fat plane. In the right side, this fat density is completely replaced by the soft tissue thickening and infiltration there. Also in the posterior periantral fat plane, here we are seeing in the left side, we are seeing normal fat density. In the right side, the fat density is completely obliterated by the soft tissue. Also, see it with, compare it with the amount of mucosal thickening present in the sinus. Though the sinus opacification is very minimal, we need to always carefully look for extra sinus invasion. Here we are seeing very little sinus opacification, but extra sinus invasion is present in the form of soft tissue infiltration of the anterior and posterior periantral fat planes. So sinus opacification, quantification of sinus opacification is not indicative of extra sinus invasion. Any minimal amount of sinus opacification can also result in extra sinus invasion. In the next set of image, we can see opacification of bilateral ethmoid sinuses. Also, there is hyperdense soft tissue thickening seen here in the right preseptal space, which is the earliest sign of orbital extension. Compare this with the left side. In the left side, we are seeing normal left preseptal space, whereas in the right side, this is enlarged and this is occupied by soft tissue. So entry through this from the ethmoid sinus, it can gain access into the preseptal space, and from the preseptal space, it can gain direct entry into the orbit. Also, we are seeing orbital fat stranding. Compare this with the left side. There is haziness, there is fat stranding in both conal and intraconal and extraconal segments, which indicates right orbital cellulitis. So this is a clear-cut case of acute invasive fungal sinusitis with right orbital cellulitis. So this is another image which is showing periantral invasion. See the normal fat density in the left to posterior periantral region. Here see the very subtle defect in the posterolateral wall of the right maxillary sinus. Along adjacent to the bone defect, we are seeing minimal soft tissue density in the posterior periantral region, which indicates extra sinus invasion. So always look for the subtle defects. Even minimal fat density can lead to debilitating effects for the patient. Also, pulmonary fungal mucormycosis can coexist along with rhino-oculocerebral form of mucormycosis. And the findings are usually non-specific in pulmonary mucormycosis. We can see either peribronchial ground glass opacities, nodules, cavitatory consolidations, multiple lesions with the predilection for peripheral location, and reverse halo sign is considered to be a relatively specific sign for pulmonary fungal mucormycosis. So the key points to remember are sinus opacification may be minimal to mild. Always look around the sinuses. Though the opacification is mild, always look for around the sinuses to see any subtle form of extra sinus involvement in the form of preseptal thickening or periantral thickening or soft tissue, minimal subtle bone defects there. And bone destruction is not necessary to classify it as acute invasive fungal rhinosinusitis. Though it may be present, it is not necessary to classify it as or tag it as acute invasive fungal rhinosinusitis. And the early findings needs to be picked up by experts, which includes unilateral ulceration of the nasal septum and mucosal thickening and periantral fat stranding. These are the early findings. When we pick the patient at this stage, we can manage the patient only with endoscopic sinus surgery and antifungal administration, and we can save the life of the patient. Bilateral disease may also be seen, though there is unilateral predilection. It doesn't mean that bilaterality cannot occur. And widen the CT window settings for evaluating fat infiltration. whenever we need to evaluate fat infiltration, we need to widen the CT window settings and narrow the CT window settings when we have to look for bone destruction. So based on this, ICRI and IRA and ICRI has given some recommendations for imaging the patients with fungal mucormycosis. Every suspected case of rhino-orbitocerebral fungal disease should ideally have MRI of sinus and orbit and brain along with contrast as per the protocol. So MRI plain and contrast, including sinuses, orbits, and brain from the frontal sinuses superiorly up to the level of jaw inferiorly, also covering the skull base, needs to be done for every suspected case of rhino-orbitocerebral form of mucormycosis. It is a good test, cost-effective, and fast, and can provide most of the information in secondary centers when the disease is confined to extracranial sites. Though imaging modality of choice is MRI only. And it has to be interpreted and reported by qualified radiologist. And communication and discussion with the clinical team is essential. Since this is a dreaded disease, it has to be communicated immediately to the clinical team, and any findings needs to be discussed with the clinical team and surgeon so as to prevent the complications, disfiguring surgery. Since it has a rapid progression, all this needs to be done. So now I'm going to show you some of the interesting cases which we have come across in the last few months. First case is a 54-year-old diabetic patient. So he is a diabetic with he is treated for COVID 20 days back, and after 20 days he presented with right-sided facial pain and swelling and painful loss of vision in right eye for 5 days. He also had altered sensorium for 2 days. So on clinical examination, he had right eye ophthalmoplegia, proptosis, right V2 involvement, and mild left-sided weakness. So we did MRI plain and contrast to the patient as per our protocol. And on MRI, we can clearly see here hypo to iso-intense soft tissue signals occupying the right-sided nasal cavity. So right ethmoid is involved. Also, we are seeing bulky and edematous medial and inferior rectus muscle. Hypo-intense, bulky, edematous right medial and inferior rectus muscle is seen. Compare this with the normal appearing left-sided medial rectus muscle. So here we are seeing adjacent fat standing in the intraconal and extraconal compartments also. So this is a case of acute invasive sinusitis with right orbital cellulitis. So direct extension into the right orbit through the lamina pepratia defect is seen. Though here we can see the hypointense signals. In maxillary, right maxillary sinus, we are seeing normal hyperintense mucosal thickening, which means that disease has not spread into the maxillary sinus cavity. Also present in the patient is hyperintense signals occupying the entire pterygoid and masticator space. So there is extra sinus invasion into the pterygoid space. Also, we saw ill-defined T2 hyperintensity, T2 and flare hyperintense signals in the right temporal region. So this lesion showed a diffusion restriction, which means that this is a case of early fungal cerebritis. So on entirety, this is a case of acute invasive fungal sinusitis with orbital cellulitis with extension to pterygoid space and intracranial extension in the form of early fungal cerebritis. So despite our aggressive management, we couldn't revive the patient and the patient succumbed to the illness later on. So next is a case of 71-year-old male with a headache of 5 days duration. He had history of diplopia and fever 1 month back. He denied any COVID history, but we thought it as post-COVID infection. And he's also a known diabetic 1 year back. On examination, he had right eye ptosis, right temporal hemianopia, loss of color vision, and right V2 loss of fine touch, and right facial weakness and loss of taste. Power was normal. So MRI plain and contrast was for this patient. Since he denied any COVID history, we did only CCT. CCT also showed non-enhancing soft tissue within the left to posterior ethmoid and sphenoid sinuses. Here we can see in the middle ethmoid sinuses, here we can see the normal enhancing sinus cavity. Posterior to that, we are seeing non-enhancing soft tissue. So this is indicative of tissue destruction. And this also is, there is also minimal extension to the orbital apex here and minimal extension to the anterior cavernous sinus on the left side. In the right side, we are seeing a normal fat plane adjacent to it. In the left side, there is loss of fat plane with anterior cavernous sinus and orbital apex, which means there is minimal extension is present to the orbital apex and cavernous sinus. So this is a case of left posterior ethmoid and sphenoid invasive sinusitis with extension to orbital apex and cavernous sinus. This patient had vision loss later on, but he was saved. He undergone surgery with endoscopic debridement and antifungal administration, but we couldn't save his vision. Here in bone window, we do not see any kind of destruction. As I said before, bone destruction is not necessarily present in invasive fungal sinusitis. So this is a typical case of acute invasive fungal sinusitis with the left orbital apex and cavernous sinus extension. So next is a third case is of a 30-year-old very young male patient. He was treated for COVID 20 days before, but he developed a severe left-sided facial pain followed by diplopia and progressive vision loss of 10 days duration. He was non-diabetic. He only had COVID history. He was treated for the same also. Then he developed facial pain, diplopia, and vision loss. On examination, he had a complete ophthalmoplegia and hemiplegia. Even on arrival, he was very sick. He had complete hemiplegia, ophthalmoplegia. He was conscious but was disoriented, and he succumbed very rapidly to the illness 3 days before. On consultation with the surgeon, he said this might have happened because of the cytokine storm, which might have existed along with fungal infection also. Anyway, we did MRI for the patient on arrival. Here we found out soft tissue signals occupying the sphenoid sinus entirely and the posterior ethmoid also. This is seen involving the cavernous sinus bilaterally. Also, there is extension to the orbital apex. Here we are seeing the typical guitar pick sign also. There is raised intraorbital pressure. There is distortion of the globe. There is compression and distortion of the globe structures resulting in guitar pick sign. So this is a bad prognostic sign. Also, in FLAR images, we are seeing ill-defined T2 and FLAR hyperintensity was present with multiple foci of diffusion restriction, which indicates multiple infarcts due to angioinvasion. So since it has involved cavernous sinus and internal carotid artery, angioinvasion has resulted in multiple infarcts for this young patient. Also in MR angiography, we can see severe narrowing of the left supraclinoid segment of internal carotid artery. Compare this with the right side. Right side, we are seeing normal lumen. Left side, there is severe stenosis of left intracranial internal carotid artery. So this has been involved along with extension to left orbit. The patient succumbed very rapidly to the illness. Death in these patients is because of intense inflammatory arthritis involving the perforating arteries from circle of Willis. So next is a 55-year-old patient with severe right-sided facial pain for past 1 week. He had no COVID history. He didn't develop any kind of fever, but he had altered sensorium for the last 2 days. Prior to altered sensorium, this patient had severe pain that he went to a dentist. He had a tooth extraction done, yet the pain didn't subside. Even after tooth extraction, he didn't have subsidence of pain. So he came to Neuro Foundation. He had no past history of COVID also. He denied any history, any traveling history. So a neurologist suspected here right trigeminal neuralgia, some form of neurovascular conflict was suspected. We did MRI for the patient. On MRI, we are shocked to find out one ill-defined T2 and FLAR heterogeneously hyperintense lesion occupying the right temporal lobe, which is showing diffusion restriction and mild enhancement on contrast study. Mild enhancement on contrast study. CT was done for the patient, which showed hyperdense areas in the inferior aspect of the lesion. In GRE sequences, we could see some form of blooming artifacts, which could be anyway hemorrhage or metal deposition. So these findings ill-defined T2 and FLAR hyperintensity with the diffusion restriction. So diffusion restriction pointed it towards early cerebritis. So we thought of some form of early fungal cerebritis. We proceeded with the craniotomy and the total excision of the lesion, and in microscopy, we found about fungal elements, which are the septate hyphae, which are seen here. Because of the rapid diagnosis and immediate surgery, this patient improved significantly. Even with the involvement of right temporal lobe, this patient improved significantly after antifungal administration. He didn't develop any form of debility later on, and he went to home after 3 weeks. So this is another case. This is a 40-year-old male patient, uncontrolled type 2 diabetes, post-COVID, treated elsewhere, but he came here for headache, left eye swelling and watering and discharge. On examination, he had left eye proptosis and multiple cranial paralysis. So we thought of fungal mucormycosis and we did MRI for the patient. And here we found out hypointense to isointense signals occupying the entire left-sided left ethmoid sinus and left maxillary sinus, along with thick and bulky edematous medial rectus, levator palpebrae superioris, superior oblique muscle with orbital fat stranding. So this is a case of acute invasive sinusitis with left orbital cellulitis. So on contrast administration, we are seeing total lack of enhancement along the left-sided nasal cavity, left maxillary sinuses, along with orbital fat stranding and bulky medial rectus muscle. So we are seeing black turbinate sign here, orbital fat stranding indicating orbital cellulitis, orbital extension is present. So it's a acute invasive fungal sinusitis with left orbital cellulitis. So case 6 is another interesting case where early diagnosis, how it will manage the patient. So here is a 38-year-old female patient. She is a post-COVID patient with minimal symptoms. She was treated in home. She was in home quarantine 15 days back. She is a non-diabetic, but she suddenly developed a headache after 15 days. She came here for neurological consultation. On examination, she didn't have any eye movement restriction and no weakness was present for the patient. So only on suspicion of a fungal mucormycosis, we did MRI plain for the patient. There we saw only involvement of the nasal septum. Here the nasal septum he is showing diffusion restriction, which means some form of sinusitis. We suspected some form of infection here. In T2 and FLAR sequences, we can see hypointense signals involving the septum and along with the adjacent turbinates. Though it is surrounded by hyperintense normally appearing mucosa in the periphery, in the central part, it is showing typical features of fungal invasion. But there is no involvement of orbit on both sides, and there is no intracranial extension was present. For this patient, we found only nasal septum involvement and turbinate involvement. This patient was taken immediately for surgery. She undergone only endoscopic sinus debridement. She improved very rapidly and she went home after 10 days. So early diagnosis, early management, early surgery, and early antifungal administration is very helpful in managing the patient. When we diagnose it late, it can spread to extrasinus structures, which will result in disfiguring surgery, though sometimes we couldn't save the patient also. As said by our ENT surgeon, no patient dies of fungal mucormycosis. It is the COVID that kills the patient. So that might be true because the cytokine storm might be the culprit in most of the deaths that occur due to fungal mucormycosis. Whenever we suspect fungal mucormycosis, when we diagnose it early, when we manage it early, we can see better results in many of the patients also. So the management is multimodality. It needs medical and surgical debridement. So medical management is by controlling the diabetes, control the sugar, reduce the steroid dose, discontinue immunomodulating drugs, and administer IV amphotericin B under supervision along with other antifungals. Surgery depends on the extent of involvement. When there is only sinus involvement, endoscopic sinus surgery can be done. When there is orbit involvement with visual loss, endoscopic sinus surgery and orbital decompression needs to be done. When there is orbital involvement without visual loss, maxillectomy and orbital accentration needs to be done. When there is intracranial involvement, rhinocerebral involvement, extensive debridement with a neurosurgeon help needs to be sought. So these are some of the images from our hospital. So here we can see the creamy appearance, creamy whitish mucor, and compare this with the reddish appearing normal sinus mucosa adjacent to it. So this is the devitalized part. Because of the devitalization, it appears creamy white compared to normal reddish appearing normal sinus mucosa. So this is another image which is showing creamy nature of the mucormycosis. So intraoperatively, it appears creamy white. So some mixed flora infection is also common. It's not only mucor, along with mucor and aspergillus, they are very common in post-COVID scenario. Aspergillus appears black and mucor appears white. So this is one case where we had a mixed flora infection. This was debrided completely. So this is one post-op specimen showing whitish appearing mucor and aspergillus blackish appearing. So we debrided completely and the patient improved also. Thank you.
Thank you, Dr. Ramchandran. I think it was very clear. You have pointed out all the differences, all the points that have to be identified. So that we can
Yes, sir.
diagnose fungal invasive fungal sinusitis early, give the patient a better result. If you have any questions, audience can unmute themselves and ask.
Thank you, sir.
Actually, I have a question, Doctor.
Yes, sir.
Actually, the allergic fungal sinusitis
Yes, sir.
and acute invasive fungal sinusitis.
Yes, sir.
How to differentiate both the things?
Yes, sir. As I said before, sir, allergic fungal sinusitis appears hyperdense in CT. So hyperdense mucosal thickening is commonly seen in bilateral involvement. Hyperdense mucosal thickening is commonly seen in allergic fungal sinusitis, sir. But in acute invasive fungal sinusitis, we are seeing only isodense to hypodense mucosa. This is because of the fungal elements. It is altering the signal intensity and density in CT. It appears iso to hypodense. Also, bone destruction, it's not so typical in acute invasive fungal sinusitis. In allergic, there can be bone destruction. In both the cases, we can see bone destruction. But hyperdensity is commonly seen in the allergic fungal sinusitis, whereas isodensity is commonly seen in acute invasive fungal sinusitis, sir.
So what I understand is it is the mucosa that is invaded.
Yes,
So
sir.
if there is no mucosal inflammation, then it is confined to the cavity, then it is allergic fungal.
Yes, sir.
If it's going to invade the mucosa, then
Yes, sir.
we call it as invasive allergic fungal sinusitis.
Sinusitis. Yes, sir.
Okay, doctor. Is there any pre-delegation for this allergic fungal sinusitis? Any sinus that is commonly involved?
For acute invasive fungal sinusitis, we are seeing commonly ethmoid middle terminates and nasal septum. They are the common predilections, sir. In allergic fungal sinusitis, I think maxillary and ethmoid both are involved, I think, sir.
Okay. Thank you. Thank you once again, Dr. Ramchandran.
Yes, sir. Thank you, sir. Thank you, sir.
Dr. Divya will give the order.
I would like to express our sincere thanks to Dr. Ramchandran for enlightening us on fungal sinusitis, the need of our time, sir. I also like to thank our honorable chairman, Satish sir, and our respected teams and Dr. Shanmugh sir for this wonderful opportunity. I'd also like to thank our MS Dr. DMS Dr. Prasanna Babu, Vice Principal Dr. Usha, Academic Director Dr. Tanushree sir, Controller of Exams Dr. PM Subramanian, and everyone who has attended this webinar and making it successful. Thank you.
I want to thank.
Thank you.
Yes, sir. I once again want to thank Dean sir for attending this meeting, sir, and Dr. Sendilnathan sir, Chairman of Annapurna Medical College and Hospital, and all the attendees who patiently listened for my presentation. Thank you.